have with us Bridget Murphy, who's got a master's in education and is a program and policy analyst at Portland State University, Reclaiming Futures. She coordinates the Conrad Hilton funded 5-site SBIRT initiative with youth involved in juvenile justice. Bridget has more than 2 decades of experience in the behavioral health field and has worked as a provider, project director, principal investigator, evaluator, consultant, and federal contractor. We also have with us Elkin, who is the executive director of Reclaiming Futures and the model developer for SBIRT JJ. Evan is an experienced clinician and researcher and a nationally respected innovator and policy advisor to government and nonprofits on treatment and juvenile justice and child welfare reform. If you have any questions, feel free to contact us in the chat box. And if you're having some difficulty there, you can always reach us at info@ireta.org. At this time, I'm going to turn things over to our presenters for today, Bridget and Evan.
Thank you, Crystal. And while we're waiting to switch the slide deck here, this is Bridget Murphy, and I'm joined here with Evan Elkin. And I'm so proud to say that the background noise there. Okay, great. That's much better. Thank you. So I'm also proud to say that I'm joined by others in the national office, including Crystal and I think with you our expert model, and we hope by the end of this session that you will be able to differentiate between youth and SBIRT models for juvenile justice settings as they compare to adult models. Also, we're going to tell you about our Reclaiming Futures SBIRT JJ sites and the implementation settings and characteristics. And then we're going to hope you recognize the special implementation considerations relevant for SBIRT JJ. We're going to pause along the way for some questions, and we're going to pause at about slide 9, 17, and after 19. So if you have any questions for us, please add them to the chat box, and we'll make sure to pause along the way. With that, I'm going to turn this over to my colleague, Evan Elkin.
Thank you, Bridget, and thank you to the organizers, and welcome everybody, and thanks for joining us. I just want to start out with a little bit of history on a brief discussion of the research foundation driving this current movement really in developing a youth version of SBIRT. I think it's fair to say that the field is in its infancy. There isn't really a strong and well-developed research literature supporting the effectiveness of youth SBIRT at this point. We're kind of in the middle of it right now. It's an exciting time for the field. But a word on where this all comes from. I think that we are buoyed by the adult research literature, and this is really what kind of got us started. We refer here in the first bullet to Dr. Brett Harris, and we're referring, and you'll see the citations at the end of our slide deck, and you'll all receive this as a PDF. We're referring to a presentation that Brett did in this venue, an excellent review of the current research literature supporting both youth and adult SBIRT. So we know, those of you who know the literature know that it's quite effective with adults and alcohol use, and has had some mixed results with drug use and adults. And it's important also to note that there are some foundational pieces of both program development, model development, and research that precede this SBIRT movement. SBIRT didn't fall out of the sky. In some ways, it's a natural development that began in the early 2000s with those of you who know the Samsung CSAT funded initiative called Cannabis Youth Treatment. And this is where the first randomized controlled trials and some of the best research on really the original brief adolescent focused interventions were first described and studied. You'll see the big fat acronym there, MET CBT5. That stands for Motivational Enhancement Therapy, Cognitive Behavioral Therapy 5. And the 5 means 5 sessions. And at that time, in the early 2000s, 5 sessions was exceptionally brief, given the framework that we understood to be the right timeline for treatment for anyone, adolescent or adult. The idea that you could accomplish significant treatment outcomes in only 5 sessions was met with some skepticism, and the results were phenomenal for MET CBT5. So it's important to note that what we are now considering a relatively new field had its foundations in some very good model development and research. We also need to credit Dr. Ken Winter's Teen Intervene model. He is also a model developer for a version of SBIRT that is funded by our funders, Conrad N. Hilton Foundation. We are in a cohort with Dr. Winters with some other model developers and folks testing other versions of SBIRT. And Dr. Winters' Teen Intervene model, which has been around for some time, which is a 2 to 4 session intervention, has been an important kind of forefather to the current SBIRT models, and our approach that you'll hear about later is inspired significantly by his work. There are other studies. SAMHSA's SBIRT study in 2012 looked at that time at the existing youth SBIRT data, showing some positive promise for SBIRT. A project called Project Chat, which was a 20-minute motivational interviewing-based intervention done in medical settings. It was a very small study without a control group, but that showed some promising findings and is some of why we, as model developers, are focusing on motivational interviewing. And I feel it's also worth noting a project you may or may not have heard about. It's not currently an active program, but it was around for nearly a decade. Columbia University back in New York had a project called Teen Screen, which was a screening program for high schools around the country. And it was the first time from a kind of public health and epidemiological standpoint, an effort both to screen and also to follow up programmatically with young people by screening an entire student body in a high school. It's the first time something like this was tried. Its successes and the lessons from that project, I think, resonate with those of us who are working to develop effective models of SBIRT today. Fun fact about me, as a graduate student, I was a clinician and a screener in the Columbia University Teen Screen project, so I do know some of the challenges and some of the positives of that project that we've imported into our model. I'm going to pause for a polling question. I'll turn it over to Bridget to describe it.
Okay, yeah, Crystal, is there? Can you go ahead and launch the first polling question?
Absolutely.
Thank you.
That question is, what do you think are the main differences between adolescent and adult SBIRT? Please select all that apply. Developmental, assent and permission, strategies for motivating change, standard norms for substance use among adolescents, referring for assessment, treatment, or supports.
So we can't see, Evan and I can't see the poll on this end.
Okay. Can you see the results now?
No. All right, is it possible just to tell us what the highest percentage is in terms of what folks thought that were the fundamental differences?
Of course. It looks like 97% of those who responded said that developmental differences were important to consider. 81% agree that assent and permission, strategies for motivating change, and standard norms are important, and 71% said that referring for assessment, treatment, or supports were the main differences.
Fantastic. I think we're definitely in the right group then. That's terrific. Thank you. And Evan is going to tell us a little bit more about some additional fundamental differences, some that were identified amongst the group, as well as a few more.
Okay, thank you, Bridget. So again, I think we need to go back to history. It wasn't all that long ago, something like 15 or so years ago, again referencing the seminal cannabis youth treatment study funded by CSAT and SAMHSA, that we didn't really have a field of adolescent drug treatment. All we had was the adult models and our learning experience of observing young people treated with adult models, with the 12-step model, working in groups primarily, and observing the poor effectiveness, poor levels of engagement, and poor levels of client satisfaction that were observed and described at that time. So we've had some lead time in the field in general, so we haven't had to reinvent the wheel in thinking about SBIRT. And some of those key factors are, when you think about adolescents, particularly adolescent brain development, and the fact that peer responses, their peer interactions occupy most of the frontal lobe of their brain and brain activity when they're trying to figure something out, and the fact that they focus much more on the here and now and don't plan particularly well. Some of that is the driver behind why sitting in an AA or 12-step kind of meeting wasn't particularly resonant for young people. It was a live kind of experiential example of why telling young people where they stand vis-a-vis others and vis-a-vis norms. It's also why using scare messaging didn't particularly work. Young people don't look at somebody whose life may have been significantly impacted by drugs and project themselves into that story into the future. So we learned a long time ago that you have to keep things really in the here and now and focus on current goals, current expectations that a young person has, and focus on strengths and empowering a young person to take control of their own behavioral change. This, in a nutshell, is why motivational interviewing has become really the go-to model overlay for youth SBIRT. Almost all of the various models of youth SBIRT that have been developed and are under testing right now focus to a large degree on motivational interviewing for these reasons, because it's very person-specific and contextual, and that's really where, in terms of brain processing, that's where young people are. One of the other differences are really what should we expect in terms of outcomes for young people. I think the adult literature on alcohol-focused SBIRT has shown great outcomes for driving adults into treatment or creating an increased likelihood that they will follow up for treatment. We don't yet know, because the literature is so young, on what we might expect in terms of outcomes. Are we looking at brief intervention to have actual outcomes by reducing use? Are we looking potentially, as some have discussed, to hold the current level of mild to moderate use, which is really the modal SBIRT client? I think we can talk a little bit about this later, to hold their use steady so that it doesn't worsen. Are we also, as with adult SBIRT, looking to inspire a young person to make some changes or to seek support in making those changes, meaning follow up on a referral? There are also questions, I think, about the difference between young people and adults. As you probably know, since many of you we saw from the early poll work in medical settings, that adult SBIRT is a very, very brief intervention. It's sometimes just a 10 or 15-minute conversation during the course of your annual physical with your general practitioner. I think that there is a growing consensus that 15 to 20 minutes is not going to be enough for a brief intervention with young people, and that we're probably looking at something, a much more developed conversation with the young person, and perhaps one that may involve their parents and certainly may make reference in some detail to their life context, their peers, their goals, their strengths. And to do that, you need a little bit more than 15 minutes. And you'll see later that we're proposing a 2 to 4 session version of all of this. So just a quick conceptual snapshot of our SBIRT model. And as many of you know from being on the various excellent webinars hosted here and others, that there is something of a cottage industry going on right now, and partly thanks to the tremendous interest in developing an evidence base around this, and a lot of really good model developers and practitioners, and also a very significant investment by the Conrad N. Hilton Foundation, which is really driving a lot of the SBIRT development around the country. That there's quite a few versions of SBIRT being developed around the country, and this is our particular version. We have based it on research evidence and our knowledge about adolescent development and our experience. But again, we are, this is a hypothesis that you see in front of you, that these core elements of our model will lead to the kinds of changes that we look for. So you can see this is sort of an embedded Venn diagram. As we said earlier, motivational interviewing principles are a primary element and really drive the theory and technique behind how the practitioner interacts with the young person. And that means that it's very youth-centered. We believe from screening also the way that a conversation unfolds with a young person, that it needs to be appreciative of the young person's strengths, their coping abilities, the strengths and assets in their social environment that they engage with. So we're not ready for prime time to display our screening tool, but we work with Chestnut Health Systems to tailor a version of the Gain Short Screener that has assessment elements that appreciate this second larger Venn oval here. Questions that are strength-based and focus on allowing the youth to talk about their own assets and coping abilities. Our version of SBIRT is a co-occurring version of SBIRT. We're looking both at mental health symptoms and substance use. So in the screening tool and in the feedback conversation in the beginning trigger of those brief sessions with the young person, both mental health symptoms and substance use symptoms and frequencies are discussed with the young person. And our theory is that you must put these things in the context of the young person's life and their goals for them to be meaningful. And to draw the distinction from the earlier slide between how this might differ from adult SBIRT, where a doctor might say in response to hearing about symptoms or a level of use, to do what we call norming, which is to say something like, do you know that your level of drinking, for example, places you in the 90th percentile, that you're actually way up there in terms of people your age for how much you drink, and these are the negative outcomes and collateral consequences you might anticipate given your level of use and what we know about norms. We have opted not to do that in our version of SBIRT. Instead, we focus on the immediate life context of the young person and how their use and their symptoms are actually affecting in real time the goals that they have for themselves and their lives, as well as asking them to imagine how a shift in the use or a change in the symptoms might affect their ability to reach those goals. And that's the beginning of those of you who know about motivational interviewing. That's how you plant a seed for change thinking and change talk, to ask someone simply to imagine what a change might look like. This model and our view of SBIRT trusts youth as key decision makers, and you'll hear a little bit later why this is a challenge. Our pilot is operating in a juvenile justice setting where trusting youth to make decisions is not something that is primary in the minds of the folks who work with young people in a juvenile justice setting. But our view is that by planting a seed for good decision making and framing the conversation around how do you make decisions around substance use and around addressing your behavioral and emotional difficulties is an important seed to plant with young people so that they have a positive experience of experiencing themselves as decision makers later when a referral might be made. Again, this is a hypothesis and a bet we're making, but even the phrase trusting adolescence is not something that sits well with most people, particularly parents. And finally, our model directly addresses the role of the parent and both parent support and attitudes about drug use. We have a parent session where we talk specifically about how rules and attitudes about drug use are communicated about in the home, and we'll talk a little bit more about that later. Next slide. This is a snapshot of how our sequence unfolds. Our version of SBIRT is a maximum of 4 sessions. It begins with a screening and feedback conversation with the young person immediately after the screening is completed, and a discussion of the impact. We call it the goals and impact exercise that I mentioned earlier in the Venn diagram. That takes place in Youth Session 1, which transitions into the next session where readiness to contemplate change and an exercise that helps the youth imagine planning for that change depending on their readiness level takes place in Session 2, and preparation for a conversation with their caregiver. After Youth Session 2, or somewhere in there, logistics differ at various sites of when the caregiver can actually sit down with the practitioner. The caregiver has a session of their own with the practitioner, discussing issues of adolescent norms and development, and preparing for the youth caregiver session together. And in that session, it's a youth-driven session where the youth talks about and feeds back to the parent or caregiver what transpired in Sessions 1 and 2 and any kind of planning that may have taken place. And let's bounce to the next slide. Just a word about our initiative overall. I've mentioned a couple of times we are grantees in a multi-year initiative funded by the Conrad N. Hilton Foundation. And this, I encourage you, if you don't know about it, to take a look at their website. This is a major investment they're making, not just in SBIRT, but in new strategies around adolescent drug use prevention. And it's a multi-tiered portfolio of grantees, not just practitioners and model developers, but looking at all of the surrounding issues from confidentiality, advocacy, and training issues. It's a really well-designed initiative and worth a look if you're not aware of what they're doing. Our initiative overall, we take a public health lens on juvenile justice. That's sort of a way that we describe Reclaiming Futures, is that we look at the continuum of juvenile justice as something that exists in parallel to what we think of as a public health continuum. If you've had any public health courses or know something about it, the idea of going from prevention to interventions of various kinds, but ahead of prevention are the things in communities that are protective, looking at the way, what they call the social determinants of health in communities. So we look at the juvenile justice system as kind of a microcosm of society at large and look for those points of access where screening, assessment, and intervention can take place, but also where we can work with jurisdictions on protective factors and bolstering and engaging in prevention as well. Our pilot of 5 sites is working at the juvenile justice diversion point in the juvenile justice continuum, the place where young people have an opportunity ahead of court to be diverted back to the community into programming or from the juvenile justice system entirely. We see this as, from population statistics alone, as a unique opportunity to access a large subsample population of young people who may or may not have had treatment access and a good opportunity to screen. Some of the challenges of working in this environment is the notion that in juvenile justice is not doesn't see itself as a public health setting, but the challenge of disentangling the task at hand, which is to bring about fair justice, is to disentangle the risk that a young person may pose to themselves or to society, or the risk of continuing down a path of offending in the juvenile justice system, and meeting their needs, which may emerge in the course of getting to know them at the front end. The challenge in juvenile justice is to disentangle risk from need, and not to do too much for someone who doesn't need it, and not to do too little and have too light of a touch for someone for whom you have an opportunity to intervene. So we're going to take a moment and see if there are any questions. And from the instructions at the beginning, there are a few different ways that you can ask a question. We will hold tight here and wait to see if there are any questions.
At this time, it doesn't look like we have any questions from our audience, but you can share those in the chat box and the questions box. Oh, we've just had one come in, actually. It says, when is Reclaiming Futures being implemented?
When is Reclaiming Future? So we've been around since 2001. We're in our 15th year in operation. So we are in 42 sites in 20 states around the country operating. We are a juvenile justice reform and public health framework that does significantly more than SBIRT. Is a piece of our operation, and is a relatively new thing for us. So Reclaiming Futures has been around for a while. We have one new site that just launched, but our first site launched in 2001. Our SBIRT project is 1 year in, and data collection is beginning now. We had a model development and implementation year, and data collection is beginning now. Does that answer the question? Bridget, do you want to add anything?
No, I think you covered it well.
All right, we have someone on the webinar who's in Washington State, and they're curious to know what sites you're at. It seems like you have quite a few of them, but are there any in that area?
Our Reclaiming Futures sites, we have 2 in the state of Washington. We have a Snohomish County site and King County, which is Seattle, Washington. And if the question is about where are we implementing our SBIRT model, I'm going to defer. We do have a couple of slides on that Bridget will talk about in a second.
And then we've just had another question come in. What is the relationship of the SBIRT model and screening to diversion? Is the brief intervention offered as a contingency for diversion?
So the way that we conceive of the relationship between juvenile justice diversion and the prevention opportunity that SBIRT poses is that it's a parallel moment in a young person's life where usually an offense that's not severe enough to have allowed them to penetrate further into the system, or it's a first arrest. From a juvenile justice standpoint, it's a behavioral red flag. And SBIRT is an opportunity also to look at, as you know, screening is usually a brief instrument that raises red flags and areas for potential follow-up and concern. So we see that there's a great parallel in the lives of the young people between this moment where they've come in contact with the system for behavioral reasons and the opportunity to ask questions about the rest of their life. Because in those settings, there are programs and structures in place rather than to draw them further into the system, but to look for supports in the community and reason to offer a lighter touch and the support so that they won't come back into the system. So it's a moment in time that we see where there's a great opportunity to bring this public health intervention. The 5 sites who are working with us in this pilot all proposed implementing SBIRT in already existing diversion programming, which you'll hear about later. So SBIRT itself is not part of a deal that a young person makes to be diverted from court if they agree to participate in the screening. It's an integrated part of an existing diversion program. As you'll hear later, one is a court diversion on a truancy program in middle schools. Another one of our sites works with PINs or status offender diversion. And these sites, as part of our pilot, integrated SBIRT into their current practices.
All right, well, it looks like those are the questions we have for the time being. I'd like to encourage our audience to keep submitting them. So there will be other opportunities throughout the presentation to pause for questions.
Thank you, Crystal. So as Evan just mentioned, we somewhat intentionally did not talk much about, or did not want to talk much about, the larger Reclaiming Futures initiative, primarily because we wanted to dedicate this time to the SBIRT model within the juvenile justice. But as Evan mentioned, we have 42 sites all across the country that have been implementing Reclaiming Futures, which is a system-level and client-level intervention to improve juvenile justice coordination and collaboration with behavioral health, the community, and other interested parties at a local level. And you can see these red stars all over the country are where our 42 Reclaiming Futures sites are. And so, as Evan mentioned, we do have a 6-step model that starts with screening and assessment and referral, And the one thing that was somewhat missing from the model was this notion of a brief intervention. And so, as Evan has coined in the office and said before, this is kind of Reclaiming Futures 2.0, where he developed a brief intervention and applied for some funding from the Conrad Hilton. Thank you, Conrad Hilton. And as a result of that funding, we issued an RFP for our existing sites to apply to implement this brief intervention, as well as sites that were also interested in utilizing the Reclaiming Futures model and the brief intervention. So we got over 20 proposals, and we were able to select 5. And the 5 sites are in Vermont, in Chittenden County, Vermont, in Nassau County, New York, in Charlotte, Mecklenburg, North Carolina, in Washington County, Oregon, and King County, Washington. So the caller that just came, or the question about what's happening in Washington is happening, the SBIRT model is actually happening in King County, Washington. And you may have participated in Jeff Miller's presentation back in September, which described what they're doing up there in King County. It sounds like somebody's off mute and doing a little typing in the background. Thank you. And then, not part of the Conrad Hilton funding, we also have just launched several sites in Ohio. Actually, it's 6 counties in Ohio who have decided to pool resources and collaborate and implement our version of SBIRT within their juvenile justice jurisdictions. And those counties are Hocking County, Montgomery County, Lucas County, Defiance County, Henry County, and Williams County. So while we haven't officially launched training with them, we're in the very preliminary stages, and we find this to be a fabulous outcome as a result of the Conrad Hilton funding, which one of the primary goals is to disseminate information and practice as it relates to SBIRT. So let me give you a few additional implementation descriptions, because that was some of the questions that came up earlier. If we look at Vermont, that is actually situated within a county court juvenile justice setting, and it is working with informal probation, diversion, and community justice center restorative alternatives. So it's young people that may have been in some violation of underage drinking or low amounts of marijuana. They can opt into the SBIRT model here. Also for New York, this is actually situated within a behavioral health organization who accepts referrals for the persons in need of supervision, the PINS diversion. And their thought is to implement the SBIRT model for kids that may not need a full continuum of behavioral health outpatient services, but may benefit really from a brief intervention. Also, then we have North Carolina, which is actually a collaboration between 3 partners. It's the County Juvenile Justice, the Police Department, as well as a prevention and recovery organization. And they're accepting referrals for diversion purposes, primarily from school resource officers, as a means of extending an opportunity to participate in the brief intervention rather than go to the juvenile justice system. And then in Oregon County, this is also in the juvenile justice, in Washington County, Oregon. It's also within a juvenile justice setting, and this is for first time and second time, primarily drug offenses or alcohol offenses as it relates to their diversion. And then Washington and King County, this is actually situated within the County Behavioral Health Organization, and it is with youth that have 2 or more unexcused absences within school will be referred for screening. And then, as mentioned, in Ohio, we're still in the very initial phases of trainings, and we're not exactly sure where the SBIRT will be situated, but it'll probably be within either a school setting and or an assessment center for juvenile justice or those types of things. We'll have more information on that later, so stay tuned. So as you can see, while we're implementing within very diverse settings, we have very diverse staff. And so the staff can range from probation officers, or sometimes called juvenile counselors, to prevention and behavioral health counselors, clinicians, school resource officers. So we have lots of varying degrees, from people that are very comfortable with brief interventions and implementing brief interventions and intervening as necessary, to folks that's really not necessarily their forte. They haven't had a lot of experience doing that. So our training has had to be adapted and modified to make sure that it's relevant to the project staff that will be implementing. And from, being able to talk about treatment planning if necessary, or higher levels of care, to what do you do if a young person reports thoughts of suicide, and those kinds of things. So really making sure that the staff feel competent and skilled to provide this brief intervention. And our training approach, one of the things that I think comes up often in implementing SBIRT is how to keep people trained. How do you keep people trained, especially if there's turnover or staff changes or those types of things. I'm saying that this looks incredibly organized, but in probably the past year, we've really been able to put some structure around our training approach. It didn't necessarily start out like this, but we were doing it. And it ranges from a basic introductory course to what we are calling learning collaborative chalk talks. So providing some overview of the basic elements of SBIRT, how we implemented our theory, our goals, how we want to view young people and their families, to operational mapping, and really walking sites through with where do you situate SBIRT within your setting, what makes most sense, and what would be most effective in terms of the outcomes for the youth and families. And as you can see, there's different ways that we provide this training, the number of trainings, and they range from very low interaction to high interaction, where we're looking for skills and competencies as demonstrated by role plays and those types of things. One of the things I just mentioned was this learning collaborative chalk talk. Each month we have a learning collaborative with our SBIRT coordinators. Each site has a coordinator that joins this learning collaborative, and the goal really is threefold. One, it's the national office, the people that are on this call talking to you, providing information to the grantees. And then it's the grantees providing information to the national office, because we really want to be responsive to what's happening on a local level and how this is being implemented and the challenges and successes that sites are having. And then it's also an opportunity for grantees to share information. And during some of these learning collaborative calls, we might show a video that provides some basic information on the spirit of motivational interviewing, or we might take one element of the SBIRT model that we're implementing and go over it for brief chalk talk. So we want to talk about goals and what does that mean, and Evan will provide a quick chalk talk as somewhat of a refresher during the learning collaborative. As was mentioned too, since this is an important initiative, we have two evaluations underway. One is being conducted by apt associates, and that's being led by Dr. Corey Sheedy, and they're responsible for all the Conrad Hilton evaluation for all the grantees, and they're monitoring information such as the number of screenings, brief interventions, referrals to treatment, disseminations. They're taking the actual grant goals and developing evaluation measures to evaluate the effectiveness. Then we also have Impact Justice, and that's being led by Dr. Angela Irvine, who is our outside evaluator, who will be responsible for conducting the implementation and analysis of our youth survey data, which we'll be collecting at 3 time points, which is at baseline, 3 and 6 months post-baseline, as well as we're conducting surveys with staff, and that will be conducted at baseline and every 6 months thereafter. And the domains that we're interested in, there are others, but this is just a brief snapshot of what will be evaluated. We'll be evaluating the strengths, the substance use, mental health, implementation issues such as training, screenings, brief interventions, referrals, as well as youth perception of the intervention, whether they found it satisfying or felt like it made some kind of difference in their life. And the staff is we're evaluating the values and beliefs of staff that are implementing the brief intervention, because the hypothesis is that if there are some, if staff feel like young people can make their own decisions and are valued, if the staff believe that, then it's likely to be communicated either verbally or non-verbally. So with that, I'm going to pause for questions, but I'm not going to pause too long because we're running out of time.
All right, Bridget, we do have one question. Is there any information to show whether there is correlation between youth that use these services and parents that may have issues with mental health and/or substance abuse?
Maybe we'll both tag team on this. So as I said at the beginning, the research field looking at impact and outcomes for SBIRT is relatively young, and there isn't really a well-developed literature looking at questions like the one posed by the participant. But we do know from the literature that parental attitudes and family functioning are critical to positive outcomes for young people in drug treatment. If you know Mark Lipsy's meta-analysis looking at the effective elements of adolescent drug treatment, which we can, I don't think we have in our bibliography, but we can certainly send it out if folks are interested in this. Having a family component and appreciating family functioning at some point in intervention is widely known to be a critical ingredient to effective drug treatment for adolescents. And as you saw in our model schematic, we are making a bet. Our hypothesis is that by addressing parental attitudes about substance use and potential, what we do in the session is we talk about potential inconsistencies in the attitude. If the parent says something like, he knows that he is not allowed to use drugs, but the parent may be themselves using drugs or alcohol in the home, and that there is some sort of conflict in the message that they're conveying, if they're able to identify that and think about that, we're banking that might be an element that leads to some greater positive change and greater support by the parent. So we acknowledge based on research that these things are related, and they certainly are. But I don't know of any research on SBIRT and family mental health right now.
Yeah, I don't either, but I do know that I have read studies. It's been a while, and I couldn't even tell you who the actual investigator was, but there is correlation between parental use and youth use. It does not mean causation, obviously. There have been studies that have found that correlation, but I've also read studies that have found no correlation. So I think some of the literature is mixed in this regard. I think for us, what we really want to encourage is, regardless of what's happening, in the home, is that our SBIRT intervention is designed to provide support both to the family, to the parent or caregiver, and the young person. So, if we can figure out ways to encourage parents to seek treatment if they need it or seek help, then I think that would be a very positive outcome.
Any other
All
questions?
Right. We do have one. In the evaluation component of the project, is there a control or non-treatment comparison group or comparison sites?
It's a really good question. There isn't necessarily no treatment. Well, there isn't a no treatment control group. It is a limitation to the evaluation. But because we are implementing in multiple sites within multiple areas, I think we can do some comparisons across sites, but it won't be a no treatment control. And we will also, and Evan just reminded me too that we're going to also be able to analyze the data based on the amount of intervention the young person may have gotten, so the dosage of the intervention. there are lots of things that we'll be able to compare.
Fantastic. I will just remind everyone you can keep submitting your questions. I know we are running a little short on time, but if there are further questions, we can have the answers disseminated after the webinar, so please keep sending them to us.
Okay, great. So I think what we're going to do, given that there's just a few minutes left, we had a final polling question, but we're going to skip that and just go to this last slide, which is to discuss some of the special considerations that we face in designing the project and that we're experiencing on the ground, just thinking about what does it mean to do this in a juvenile justice setting. You know, as I mentioned earlier, SBIRT for adults really began in medical settings with a clinician in the role of interventionist. And so one of the things that we're studying, as you see that we're also, the researchers are also surveying the practitioners as well, is this basic question is, from a professional standpoint, do staff at this professional level in these professions, are they willing and able to effectively implement SBIRT and be SBIRT practitioners? And this is an open question. We believe that you can. We've crafted our intervention based on the idea that a lay person or a person who is not a clinically trained practitioner can do this. So some of the special considerations, we sometimes talk about behavioral pre-screening, and you've heard a lot about the research literature on prevalence rates of mental health and substance use in a juvenile justice population. And we won't get into that necessarily, but I think that in general you can assume that by the time that a young person touches the juvenile justice system, they're likely to have higher baseline levels of drug use and symptoms of mental health. This is based on the research that we have. So that when you look at that bell curve and you're using a screening tool is really about looking at populations and figuring out who do you need to worry about. This is a population in juvenile justice that we already know is a little bit shifted to the right on the bell curve. We also know that they have higher levels at baseline of trauma and situational distress. Just the experience alone of being involved in the juvenile justice system, being arrested, very likely having been detained once or twice during the process, brings about a certain amount of distress. And when you're asking kids in real time how they feel, you need, since part of our strategy is to contextualize symptoms, we need to appreciate the context that these symptoms are being reported, and that this is a stressed out population with high rates of trauma. The other important thing is that in this environment, there is high pressure to intervene with low and moderate, and I mean low and moderate use and low and moderate patterns of mental health symptoms. In general, in juvenile justice, there's a pressure to do something. And the idea in this public health concept, people refer to SBIRT as a public health intervention, which means you presume a continuum of need from low risk or no risk to high risk, and somewhere most kids will be in the middle and may not require a referral for an expensive or intensive intervention. This is not a framework that's comfortable necessarily in juvenile justice, where the field has generally been had kind of a hair triggered to intervene with all kinds of kids with any hint of any difficulty whatsoever. I mentioned earlier the notion that risk and need are often difficult to disentangle. Is marijuana use a risk factor for more criminal behavior? Is the fact that someone is depressed, does that should that inspire you to think differently about the disposition of that young person from a juvenile justice standpoint? So these are live issues facing decision makers every day in courts, and we know that this is true whenever you bring in a decision-making tool like SBIRT, that these factors will come in. And the other thing we wanted to talk about was in the standard public health sequence, which proceeds from screening, and if you get a red flag, you refer that young person for further assessment. If the assessment indicates treatment, you refer them for treatment. In a juvenile justice setting, all bets are off, and there's all kinds of jumping around and steps often skipped, where screening tools are often used alone without further assessment in court settings to make treatment decisions. And so our view of SBIRT, one of the outcomes we hope for from a systems standpoint, is to bring a more rational and stepwise approach by contextualizing symptoms and helping decision makers to understand who kids are, where they're at, and really to understand the level of concern that you might have and to make a higher quality triage decision into treatment or not. And that's what we have. Here are some citations. You'll all get a copy of this PowerPoint, and we'll open the floor to questions if we have any time at all.
I think we might be out of time, I think, right, Crystal?
We are out of time, but I will make sure that any questions that come in get sent to you, and then we will be able to send those out afterwards. I want to thank everyone on the webinar today for their great questions, and I want to thank both of you, Bridget and Evan, for such a great webinar. At this time, I'd like to go over our evaluation and CEU instructions. You will receive a few emails from us following this webinar. In these emails will be a link to the recording of the webinar, as well as a PDF version of Bridget and Evan's slides. Also included in that email is going to be a link to our evaluation. Our grant evaluators are required to collect feedback from all event participants. Completion of this evaluation is critical to maintaining our funding and continuing to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for Certificate of Attendance or NADAC or PCB CEUs. Should you choose to skip the evaluation and proceed directly to the CEU request, leave all the answers blank on the evaluation. Again, I'd like to thank everyone for their participation today. And if you have any questions, you can feel free to email us at info@ireta.org.